My arguments why it is still relevant is, on the one hand, we know that though this is only a small subgroup of CLL patients, but rather young and physically fit patients who are able to tolerate the FCR regimen, the most intensive regimen, and that those patients, when they have a genetically very good risk profile as a mutated IGH status and additionally no deletion 17p or other poor prognostic factors, they are doing extremely good. So we know from long-term follow-up that more than 50% of those patients are still in remission, and we see from MD Anderson data that even beyond 10 years, patients are still in remission and are still MRD negative. It's difficult to talk about cure because so far we know that CLL is an incurable disease, but in those patients we really don't know if they will ever relapse, or at least if they relapse, if that's occurring after 20 or 30 years, so very likely at a time point when they will not require a second-line treatment. So this is one argument. Another argument is that we have now in CLL a sequence of different treatment regimens. So we started so far, most countries, we still start with chemoimmunotherapy, then we switch to Ibrutinib, after Ibrutinib to Venetoclax. We do not yet know very much what happens after Venetoclax failure. There are some data that other treatments are not working very well. So with respect to the fact that we would like to have a long sequence of treatment, if we omit chemoimmunotherapy, and it probably doesn't work very well after the novel agents. So if we omit chemoimmunotherapy at the beginning, we might even shorten in some patients their life expectancy. Other arguments are, of course, the costs of these treatments. They are 5 times higher than with the chemoimmunotherapies, and also that the compliance in patients, particularly to a continuous intake of oral substances, is difficult. We see many patients stop treatment because of adverse events. In the clinical trials, it's ranging between 30% and 60%.